presentation,
Yeah,
please?
yeah, thanks, Rachel.
I've started that.
Yeah, we have been like, putting all of the recordings, Carla, into a YouTube channel, and we have shared the link.
Yeah, it's just today's hadn't started yet. That's
Yeah.
why I mentioned it. Thank you.
Thanks, Rachel. So those are the two things we are going to cover. I don't think that will take a long time. So I felt we will probably have a bit more time, and I wanted to talk about the HDR UK Gateway, which we have been talking about. This is, the Health Data Research UK metadata gateway that we have to populate our metadata in. This is one of the requirements from the national team as part of the London SDE funding, and that is done by the London Analytics Platform team. So I thought I will talk a bit about that so you can see what goes in there as well. So that's really the agenda for today. So the first thing we wanted to start with was last month, when we discussed the CVD action and the mental health dashboards, what I asked everybody to do was take away, those dashboards. We shared, some materials in relation to the dashboard, the user guides, some video, etc. So one of the ask was to take it away internally, discuss it within your data digital leadership group or whatever you have set up, whatever you call that group, to, help feedback anything in relation to this dashboard, whether, it's about, some of these key metrics are missing, or whether, the functionality is missing, or whether the visualization isn't, fit for purpose, whatever. If you had any feedback, we asked for that to come through. And we shared, two ways to share that feedback. One was to email the London Analytics Platform mailbox, and the second is to complete a web form, which Rachel had put together from her team. So Rachel, have we received anything from any ICS?
No, I haven't had any response on the feedback on those two dashboards yet, or any correspondence about access or anything. I assume access is fine for those that have tried. Have had one response in about access, but again, I think that's sorted now. So just waiting for some feedback.
Yeah. And what Rachel means by access is we have created demo versions of all of these dashboards and put into a demo site. And we shared the link, etc., as part of the one email that was sent at the back of last month's meeting. So if people have problems accessing that, do give us a shout. Which ICS had a problem, Rachel? Was it Southeast that had a problem?
No, it wasn't. Sorry, it's okay. I can take it offline, but no, it wasn't one of the ICSs.
Oh, okay. All right. Yeah, because I know Dean said he couldn't access in the call. And then, we were saying it should be fine. I don't know, Dean, whether you tried afterwards at all.
I did. It was because I was not accessing it at the time through the VPN properly, which I should have done. So we got that resolved afterwards. So as soon as I went through the VPN on the NHS network, it worked.
Perfect. Thanks, Steve. That's why I was wondering whether it was Southeast, because I know you mentioned in the meeting. Cool. So if I may leave that as an action again for people, we'll continue to talk through all of these dashboards over the course of this meeting as well as January's meeting. So all feedback to be sent to the LAP mailbox. And we are going to have a discussion, hopefully in the January data board, One London Health Data Board, to understand what are those two dashboards that the One London Health Data Board wants us to create at the London level, in the hope that, there'll be some decision. Okay, so on that note, Rachel, shall I pass on to you? Unless anybody has any comments on that. I can't see any hands or message. So let's start with the learning disabilities dashboard.
Right, I'm going to share my screen. Okay. I hope everybody can see my screen and see our demo version of the Learning Disabilities Dynamic Register. This is a radar dashboard. So it's what I mean by that is it's created to show patient identifiable information. So this is a list of patients that would be shown who meet the criteria. The criteria in this case is anybody with a learning disability condition recorded that information comes from the GP records. This dashboard was particularly created in order to understand per patient how much of a risk they had in the possibility of attending hospital or having poorer outcomes, health outcomes. So identifying particular areas of care and need, and using different thresholds per metric to RAG rate whether those were more at risk or not, and essentially give an overall sort of risk score in order to sort these lists from high risk to lowest risk for that. So on this dashboard, for anybody who was here last time or watched our videos before, you'll see that there's some similar filters along the top. So for anybody who has access to this dashboard, they only have access to their patients, whoever they have a legitimate relationship with. But if they have access to quite a number, maybe across the board, maybe it's a PCN, something like that, there's always the usefulness of being able to drill down to specific individual practices. Anybody with multiple PCNs could choose by PCN, or if there was a scenario where they had access across borough, then again, you can choose by per borough. So I'm going to just narrow this list down a little bit further and look at the H&F demo patients. So what I can see here is I've got a total number of patients who meet the criteria. So this is telling me I've got 516 individuals who have a learning disability condition. And over here, this is if I had more than 1,000, the dashboard restricted to the top 1,000, but any user could change that and make it higher. But obviously within my list, I've got under 1,000 anyway. We've got a sort by. So at the moment, it defaults to the total risk, which I've briefly explained that this dashboard has been built in order to calculate a risk score per patient. And but it might be that we want to look at these patients in an order that is different to that. So there's other ways to sorting this list of patients. And on the far right-hand side, there's a high-level graph just to show the distribution of patients per the different risk percentiles. So those with the top number of risk scores, there's 75 patients in this fifth risk percentile with an average score of 5.7, and it goes all the way down to 1 with an average score of 1.5. And I will explain as we go through this dashboard how that gets calculated. So on the dashboard, we have the list of patients that meet the criteria per for the H&F borough. This is obviously our demo site again, as I said, but we've got the NHS number, their name, their age, and then the spend, which is calculated based on a number of different areas, but this is specifically around the LD patient groups. And then we split the metrics into 3 key areas for this particular use case, and we've got social factors as the first area, then the service usage in the last 12 months, and then finally health checks. So each one of these areas, there's been a defined number of metrics that relates particularly to people with learning disabilities. So when designing this dashboard, and we consulted with those who work in the learning disability program and the mental health and learning disability program, and with the clinicians who specialize in those areas, these were the key metrics that they said were really important to determining whether somebody would be at risk of admission or hospital attendance and poorer health outcomes. So in essence, this dashboard here is really to highlight individuals and where, and not only the individuals, but also the areas where improvements could be made. The RAG rating is fairly straightforward. Being red is not good. That's an improvement area that would really need to be looked into. Amber is more of a warning. It's a possible area of need, and green is something good. This is something we would expect to have in place. It is in place, or it's regularly in place. And the risk scores that are coming out of this are all based on this RAG rating scenario. So any red that you see along for a patient would be given a score of 1.5. Amber is 0.5. Anything green or blank would be a no score at all. Now, in some of these cases, what we'll see that, so if we take social care under the social factors area, we'll see that we have ticks where we know somebody is involved with social care, but we've also got some blanks. If we know, or if I take substance misuse, we've got red where we know somebody's recorded with as a substance misuser, or green where we know they're recorded as never misused any substances. But we do also have blanks, and that's because through the coding there is no answer to us one way or another. Okay, so it doesn't clearly define that they are or aren't a substance misuser, so it's left blank. So I'm going to quickly run through these metrics along the top just to give some clarity on what's included on this dashboard. So the first metric is the language barrier. And that's really looking to see if anybody has been recorded as requiring an interpreter of any sort. So we're pulling that information from primary care records to see if a interpreter is required. I can scroll down the list a little bit further, and where we see the red dot, it does mean that they need an interpreter. There's an example there for you. Section 117. If they've had a section 117 in the last 2 years, this again will be indicated. Do they have a family carer? So across this indicator, there's a number of different possible descriptions that would mean that they would indicate to us that they have a family carer. As we hover over these ticks, we can see there in the tooltip at the bottom that in this case, the relative is an informal carer. And as of, and we've got the date there for 2014. So it's a bit of further information within these tooltips as well. Are they known to social care? So from the local authorities data set, we can see if they are known to social care, and not only if they're known to social care, but what are their primary reasons for being seen by social care. So in this case, it's for home care, and it might show us a few different primary reasons for being seen by social care. As we see through the tooltip, that can change per patient. Substance misuse, previously mentioned, we've either got, yes, we know that they are a substance misuser, and that's because it's recorded and there's a code associated with that, or never been a substance misuser, which is why it's green. Any blanks mean that we don't know either way. Socially isolated, in this case, we do have 3 colours for the RAG rating. Red, we know they are coded as definitely being socially isolated. Green, they are not socially isolated. So again, definitely showing that they are not socially isolated. And all the ambers are indicators. So there are particular codes where it might be telling us that they could well be socially isolated. So, for example, if there was a death within the family or inadequate support from family codes, those sorts of codes will indicate there is a potential for being socially isolated. The next section is the service usage in the last 12 months. And this is utilising data across from a number of different data sources, such as SUS, general practice data, mental health data. And for each one of these indicators, they should be fairly self-explanatory, but I will very quickly work through these. So we've got the A&E walk-in UTC attendances, and however many there have been in the last 12 months indicates on to top of this amber dot here. So we can see the latest 3 that have been attended, what dates they were and where they have happened. So the last 3 for this person has been at the urgent treatment centre and the dates for those. Same for mental health admissions. We can hover over the dots and it gives us the number of the last 3 admissions and if there have been any days actually spent within that, so a continuous block of length of stay is well mentioned within that. Elective admissions, non-elective admissions. We have referrals as well. So again, where this is coded, we have referral information. So we know if that's come through, but this is coded through from the GP surgery as a SNOMED code. DNAs, we get DNAs through outpatients, primary care. And for each DNA in the last 12 months, it is again counted. So as these go past their threshold. So in this case, if it's 3 or more in the last 12 months, it goes red. Comorbidities. So there is a defined list of comorbidities. This isn't any comorbidity at all. So for learning disabilities, it's a select list of comorbidities such as a mental health or challenging behavior, ADHD, if they have any psychiatric conditions such as schizophrenia or eating disorders. So there's quite a number of really specific comorbidities included in order to count that. And all of that is listed out within the user guide to be really clear on exactly what is counted within this. And then we've got last on the service usage is the number of GP contacts in the last 12 months. Finally, on the right-hand side is the health checks. And then we've got 2 particular health checks looking for, which is the annual health check and the health action plan. So red if they haven't been done or not been done in the last 12 months, and green if they have been done in the last 12 months. And all of that then, looking at all of that information, will end up giving these patients a risk score. And as we're sorted by the total risk, the people at the top have the highest risk score. So the dashboard can be used in order to identify those individuals, check out the metrics within that dashboard to see where the particular areas of need could be, and then to take action as appropriately. Carla, I see your hand up.
Yeah, I was just I have a couple of questions, but I'm wondering if the easiest thing would be whether we could have access to basically the logic behind what determines that RAG rating for each thing, because
so what I'll do,
I think
Carla,
I'll have one question after another. So I think it's just about kind of understanding what do we think good would look like in here. So for example, in the GP visits, I think we can't see enough to spot any green. So usually when we think of learning disabilities, our main worry is that patients are being missed off the system. So they have no context. They're kind of what is no longer allowed to say, but kind of hard to reach population. So having a lot of context, and depending what you define by a lot, could be a good or a bad thing. And it's potentially even worse to have no contacts at all. So it would just be good to kind of understand all the dynamic of all of the metrics together, because just one in isolation doesn't give you the answer. So
no
we
problem.
probably just need to
put
see a
in
list.
the chat the link to the user guide, which gives you a lot of that information, and we'll send it out after the meeting anyway. But just in case you wanted quicker access to it, it's there now. And if you've got any questions once you've had a look at it, please do get in touch through the LAP support mailbox, and I'll be more than happy to help you through that.
Yeah, Carla, we want to like package everything into a single email so you don't have to look at multiple places in the chat, etc. So we will do that. And also, your point about, a lot of red here, this is demo. So there's no real data. This is just made up data. So bear that in mind. It's, just scramble data for the purpose of this demo.
And sorry, I've just seen in the chat a question from Amy as well. So this is about risk of admission and about improving health outcomes. That's what this dashboard's looking for.
Cool. All right. Thank you, Rachel. So anything else anybody has as immediate questions? Xavier?
it's just on, Rachel, what you were just saying about it being about the risk of admission. So has you done any work to sort of evaluate how well it predicts risk? So if you looked back, a couple of years, for example, how well it does at predicting the risk, or does it predicting the risk of admission?
Directly, no, I haven't. As far as the programs go, they use this to on a individual patient basis in order to improve that from a patient view. But I do understand where you're coming from with that, but no, I don't have that information.
Thank you.
Great. Yes, Pete. Yeah, we have an updated set of SNOMED codes because we have converted all the read codes to SNOMED. Is a user guide that you
No,
shared?
because it's not converted. Sorry, it's in the process. I should be just as the questions come out. We're actually right at this point in time updating all of that. So in the next month, the user guide will reflect as soon as the dashboard actually changes to reflect that as well. So at the moment, the dashboard is using read codes, but with the changes that are happening at the moment, it will reflect SNOMED codes.
Yeah. Yeah, Amy, we have answered. It's a risk of admission. That's what we are trying to look at. And it's been co-produced, the actual logic of, what determines the risk of admission, as Rachel mentioned. Amy, did you want to come back in?
Yeah, I mean, I just wanted to kind of echo the point made earlier. That'd be good to know whether its predictive power, and whether that's been tested or there's any plans to test that. The other question for me, I was just looking through the user guide and I couldn't see anything about physical health comorbidities. I know that there's whether the person has had the health check or not, but how does this cross over with long-term conditions, for example? Would you have to look in a relevant long-term conditions dashboard for an LD flag, and come at it that way? Do you see what I mean?
Yeah, I understand, Amy. So the short of it is that wasn't the requirement or the need at the time for building this dashboard, which is why it's not included. The data is absolutely there, and you are right. It could be done from other dashboards from the other direction in, which services may well have been using. But again, this is the sort of feedback we'd like to hear about what it would actually mean to your ICS and how or what would be missing in order for it to be utilized effectively for yourselves.
Yeah, absolutely. Amy,
yeah, I think something that interlocked more would be more helpful. Happy to talk about that offline if that's useful.
Yeah, thanks, Amy. It's a bit like, the mental health we showed last time, right? We had built a, physical health check for mental health patients. So absolutely everything is possible. Treat this as almost a starter for 10 to guide you through what is missing and, to help us get to a place where, it can answer all the questions. Everything is purpose-based. All these dashboards are purpose-based. And when we started, developing this prototype, it was meant for a specific reason, and hence why it's captured a specific thing. Just not because that's what is possible. Quite a lot is possible. Great,
yeah,
Amy.
Sorry to come back in again, but just thinking about it, so it's got social factors in it, but there are demographic factors, like deprivation.
Yep.
Those sorts of things that would be helpful to have. I mean, in some ways, it's more about, I don't know if I can articulate this very clearly, but it's a little bit more about, rather than having very specific dashboards, having a way of kind of curating your own dashboard based on a whole set of criteria that you may want to apply. I would like to really understand, I don't know, not necessarily, I'd like to understand people with cardiovascular disease with high levels of deprivation who also have learning disabilities or who also housebound or those kinds of things, and being able to kind of create your own lists and populations by being able to to pull and select from a whole set of criteria.
Yeah.
That's almost, I think, in the long term going to be as valuable as having these kind of bespoke products.
Yeah, yeah, completely agree, Amy. So, I don't know whether Rachel shared, but if you look at the top, basically you have, the ability to like filter for patient segments, age or deprivation or ethnicity. So to your point, what would happen is in a real world setting, what you would do is like, go and pick up one of your boroughs or one of your PCNs that you're interested in because you're having a multidisciplinary team meeting within that PCN, focused on learning disabilities. You go filter for that PCN, and then you say, oh, I want to like, look up my Asian or Asian, British population, filter for them. And then because Tableau is dynamic, it keeps filtering, and then which patients come up, and you're basically discussing them. So that's really how this is used in a real world setting. And then, there's a discussion about who's best placed to like, provide care for this patient. Is it, community should be involved or social care should be involved, etc. So it's meant to give that sort of population health managed approach to dealing with the patient and, ensuring, right care. Carla.
Sorry, this is more of a theoretical question. It applies not just to the dashboard, but it kind of just occurred to me because of some of these conversations. If when we circulate to our, in this case, LD leads in Southeast London, if their views are slightly different in terms of kind of the criteria that's currently being used, I assume kind of you'll want to hear that feedback, assuming that there is no consensus across the group. And I'm not entirely sure I know if each dashboard has a separate working group or kind of where those things should be raised. I think I'm just thinking worst case scenario, and hopefully you won't come to that. But if we have differing needs, is there a possibility of using the same base code but changing some of the criteria, or basically how do we resolve if we can't get a uniform view across the whole of London?
Yeah, really good question, Carla, because we have to think of that, and it is quite a possibility, right? That might happen. So I'll answer your question in two parts. The first thing, to your point about whether there will be a separate group, yes, there will be, but we are unable to set up the group because we don't know which 2 or 3 dashboards we want to set up at a London level. So I'm waiting for that clarity so I can bring the right people. Because as you say, if it's LD, then you bring the LD leads. If it's mental health, you bring the mental health leads, right? You can't just set up a user group and then, include everybody, which is not a good use of people's time. So that's where it will be discussed to come up with a consensus. And to your second point, then, if there is no consensus, then, we have a standard set of code and have like a standard set of metrics, but, allow for that localization for the individual ICS so they can add, additional bits of metric or, additional nuances to their code. But like you, I'm also hopeful that we won't get to that because at the end of the day, we all provide, look at the same area and provide the same care. And I'm hoping there could be a consensus amongst the operational and the clinical leadership of that particular disease area. But that will be the way forward. If there is no consensus, we'll have to allow for nuances. And that's why, within the London Analytics platform, the first couple of demos, as we were demonstrating the environment, we have the London Analytics platform environment, and then we have individual sandpit areas for each of the ICS to allow for you to take the data and socialize it and, create your nuances. So technically also it's been made available like that for a reason. Okay, Rachel, is that it from you then on LD?
Yes, thank you.
Perfect. All right, thank you. So I'm going to move on to the next dashboard then, if there's no further questions on LD. No. So the next one is the primary care systems metrics dashboard. And again, there was a lot of interest in having a dashboard like this. So we have like a starter for 10, which we have pulled together that has been created in Northwest London with, primary care stakeholders. So I will bring it up and start to talk through that. Is it moving?
Kavitha, I know you did this last time. It is quite useful each time to do a reminder of like, right, yeah, like this, right from the start, how you click in, which one it is, because I think that it's that kind of constant reset, and we'll probably point people towards 36 minutes of this particular recording, so it's kind of good to go in from the start, I think, from the landing page.
Kavitha, do you want me to show that bit while you're?
Yeah, it's
Were
just
you okay?
my sharing thing is hiding it, so I couldn't move. I had too many. Thank you. Thanks, Rachel. I've got it now. Yeah, do we have that, like, we have the primary care SOM in the demo version, haven't we, Rachel?
Yeah. So if you bear with me a second, then it will take me like 30 seconds to show through this. So I'm going to take over.
Okay. Just to take Dean's
Yeah.
feedback of where people come from.
Yeah.
So this is the demo site that we shared, which Rachel put again in the chat. So if you click on it and then go click on the LAP demo, it will list all of the dashboard, and there is one right at the bottom which is called Northwest London PC SOM dashboard. So SOM stands for System Oversight Metrics. That's what it stands for. If Rachel goes on to the intro page, you will see that basically this has got just a few lines of text that introduces the dashboard to somebody who's new. So what is the purpose of this dashboard? This purpose of this dashboard is basically to celebrate the achievements of primary care, demonstrate the breadth of work that gets carried out by primary care, identify where they are performing well, where they are not performing well, compared to their peers, and to help them move to a target, and using basically a quality improvement methodology to improve the care they provide to the patient that they serve. So that's really the intention of this dashboard. And as you can see, on the top right, there is 2 pages. So there's a lot of metrics, and we have split it into 2 pages. So if you go into page 1, Rachel, to start with, page 1 captures a lot of the, sort of planned proactive care elements that, primary care carry out for their patients. And this could be a range of things. This could be the cancer screening, the cervical screening, bowel screening that they carry out.
Apologies, my internet's playing up. If you've still got it there, Kavitha, do you want to swap onto yours?
That's fine.
Sorry. Yeah, thank you.
Yeah, so the primary care teams have got a lot of work, they do on a regular basis. Basically, this is their BAU work. This is their planned, care side, acute providers. So they carry out screening for cancer patients. They carry out vaccination for the eligible cohorts. They do health checks for, mental health LD patients, and they do long-term condition checks. So all of these, are what they do on a regular basis, and there is certain targets they have to maintain, and they have to screen, vaccinate, do their health checks for the eligible cohort. So what this is trying to do is provide, them, this is what is the eligible cohort, of which how many needs to be vaccinated, what percentage have they vaccinated till date, what is the total, flu vaccination plus contraindication plus refusal, and what is the target that needs to be met. So this gets updated on a regular basis, weekly basis, so they can keep tracking the progress that's made. They know, what they need to do to get to their target. That's really the intention of this dashboard. So every metric operates like that. So flu vaccination, you can see, and then we have a very specific, flu vaccination dashboard where, they can get into nth level of detail about the individual, cohorts, the JCVI cohorts, and where, there is good progress, where there is no good progress, to help, the practices focus on those cohorts where, there isn't enough progress to keep up their rates of achievement. If you hover over this percentage completed, what you can see is the flu vaccination completed and the trend over time. So we can see whether it's going up, it's static, or it's coming down. and how, it compares this year, how the activity compares this year in relation to previous year. So they can see whether they are doing better, worse, etc. So all of these, bars operate in that same way where, they are able to see the current year versus previous year. The childhood immunization, again, is the percentage of patients that have completed the full course of immunization appropriate for their age group up to 5 years. And eligible cohort, the total vaccinated and the, childhood IMS completed. There are a number of there are a number of vaccinations included within this childhood IMS group. It's like a big group, and all of those are taken into account in order to calculate this. And again, there is a very comprehensive user guide that states which, immunizations are included as part of this for the, users to see. The target for this is 90%. And again, there's just 1/3 way, and there is a long way to go according to this dashboard. So they can start to work through that. In terms of SMI health check and physical health check, again, the eligible cohort is calculated, how many completed, how many to be completed, and what is the progress rate, and how, the progress this year compares to the previous year. Again, they can see similar principle, as I said. So all of these metrics work the same way. So you sort of get the gist. So I'm not, going to go down and, keep talking through each one, but the same applies for long-term condition health checks, for heart failure, atrial fibrillation, diabetes, hypertension, as well as cancer referrals. If you want to, look at a particular, the reason why cervical cancer and bowel cancer is not here is because we develop specific dashboards, and when you click on it, it takes the user straight into that cervical screening drill through. That's how we have developed this. But because we are going to be talking about cervical screening and bowel screening in the next session, I won't work through this now. We can go through. We can. Gosh, I don't know why it keeps hiding my. Okay, so. Okay, so if so that's how, all of these left-hand metrics are, set out. And like, the previous dashboard, all the dashboards have standard filters. So if a particular borough wants to see how they are doing, they can just click on their borough, and all of the information below will change because it'll, then filter to that, particular borough that we have focused on. Similarly, PCN, GP practice, gender, ethnicity, and deprivation. So that's how we know it's set to work. You can see here also on the right-hand side, it's gone to the borough that we have filtered on. So the entire dashboard will filter based on what you pick at the top. On the right-hand side here, there's an ability to again, go and look at any particular criteria, whether you want to look at gender or PCN or practice, anything you can pick, and you can compare a certain metric. So if I leave it as SMI health check, you'll be able to see how all of the practices are doing against the SMI health check. So it will start rating top to bottom, and you can see what the Northwest London average is and how each of these practices are doing. Clearly, there's a demo site, so there's so just take it with a pinch of salt in terms of all of the values. It's slightly scrambled. So that's what happens, and then you can see. So if you want to as I say, look at it by deprivation, if you're focusing on your inequalities, want to like see, is there any inequalities that exist in terms of SMI health check? Is there any variation between the highly deprived versus low deprived? You can again see that in like, a quick glance. Or ethnicity, again, if there is any variation. Why? Because, all of these is used to like target the right patients, to think about how you intervene, how you contact, and, what, what approach you take in terms of like, reaching out to the specific communities to get them to come and get their health checks done or whatever, like, vaccinations, etc. So that's why, this has been set up. So that's the premise of, this first page. So the first page is all, metrics that, a lot of you will be familiar with, and I'm sure even like report in various different ways. We also do that within our BI team. We have like, pretty much reports, dashboards for every single one. But what this is meant to do is to bring everything into a single place is one. And the second thing is to automatically update. So there is no manual mechanism here. All of this like, gets refreshed on like a weekly basis, monthly basis, depending on what we set as our refresh, because it has the underlying data model set up. We agree to refresh this on a monthly basis because on a monthly basis, we have a primary care system oversight group. And, this information goes to the primary care system oversight group for them to review how they are doing in relation to a lot of these metrics and who, is not doing well, who's the outlier, which borough, which PCN, and what can be done with them. That's really how the narrative is prepared for the system oversight. But if you wanted to look at it and, on a weekly basis, absolutely possible to refresh it on a weekly basis. Then we have a page 2, which is, moving into some of the other softer metrics around CQC rating, patient survey, serious incidents, all of those things, which, is not something that, gets looked at all the time in relation to QOF or anything, but still really important to understand the patient experience and the performance of, the general practice as a whole. So we have about 5 things that, we said we will focus on as part of this proof of concept. One is the CQC rating. So how are the general practices doing in relation to the CQC rating? You can, see the breakdown of the general practices by, whether they are good, requiring improvement. You can see, how many practices are in each of the category and, what can be done to work with those general practices to move them from like, requiring improvement into the good category. So that's one area. The second area is looking at patient survey. And again, starting to look at, how the general sort of experience is looking like for patients dealing with these general practices. If they have a good, sort of service, or if there's fairly poor, very poor, what percentage of very poor are we seeing? Which practices or PCNs does this relate to? And what could we put as a bit of an action plan in order to like, help improve the situation? So that's the second area where, which we said we will focus on and, work with our general practice. The third area is ethnicity recording. So we have got, a real emphasis on improving our ethnicity coding in general practice and agreed that as a bit of a monitoring criteria. And that's what we look at on a regular basis. Again, we pull a specific report to general practices, which starts to show practice by practice, how many practice have got ethnicity not recorded, how many patients don't have ethnicity recorded for those practice, so they can start to focus on it. So this overview dashboard basically gives that percentage. And then if you, because you can go down by practice year, you can go and start to look at it practice by practice. So if I like, pull one practice, you can see they're probably, different 89% was the Northwest London. See, this particular practice is 95, so they're doing much better. So they can focus on their own area if, we go down to a practice level or a PCN level. And the fourth area is looking at the first language recorded. There is more, as we move into more and more population health managed approach, there is a need to like, intervene with these patients to help improve the care. And as we are intervening, we are thinking about leaflets, updating websites in terms of how patients can contact the services that's been set up, etc. And a lot of this is done in English. So we have, started also, like we are focusing on ethnicity, focusing on first language to see if English is not people's first language, how many other languages we should have all of these materials created in. So that's why it's really important to get this recorded so we understand the most languages that get spoken by the community in our sector, so we can ensure that all of the materials are in the language that people understand. So that is a fourth area of focus. And finally, we've got the safeguarding codes and starting to check if those are being populated in order to capture any serious incidents that happens within the general practice. So currently there is a whole emphasis being given to, look at quality framework, to think about if serious incidents happen, how those serious incidents will be dealt with in primary care, what is the escalation path, and, at what point does it get communicated to the other care settings? Because there is an interface between primary care and other settings. There will be certain incidents that we need to communicate, certain things we mitigate within primary care itself, etc. So that framework has been developed and is being discussed at the sector level. So this becomes, the data that helps them focus on that quality improvement. So those are the 5 areas that goes on in this page. Dean, do you want to come in?
It was only a general comment. Obviously, I hadn't seen this before today, and I was quite excited to see this, hoping that it would be a good drawing for the GP and primary care community. Although all of this is really important, I'm a little bit concerned that it'll be a hard sell, because one of the feedback points that we've had consistently for years and years and years, and we still hear it all the time, is we're not putting our data into anything that's going to be useful performance management. And although you've talked quite rightly, Kavitha, about quality improvement and population health, etc., effectively this is something system overview, dashboard or system overview kind of metrics or whatever, that allows comparison between practices and overview at a certain level and people's performance, etc., etc. So from an engagement point of view, I can see us really struggle in South East London. I don't know about other places. I could see us really struggling with this as something that people would kind of support to be used, or something that would help us to get the data in the first place. If this was a tool, and I've fed back a little bit in the chat on the LD one as well, if these were tools that showed population level metrics, place level metrics, practice level metrics, etc., and it keeps drilling down like we've talked about before, and lands in a kind of registry patient list, and then you can click through to an individual patient, in that way, I think that's different, because that's, you can explain that benefit to anybody at any level, and say, look, ultimately this is about direct care. This is how we can influence individual direct care. We can get down to that level. You can access that level of information, etc., etc. It then becomes something that, okay, we are looking at quality, sort of benchmarking and differences in numbers and things at that level, call it performance, whatever. But actually, if you use the tool in this way, it can help you to direct your care. So it's just stuff for us to think about. And the same with the LD one a little bit. I know there's a registry list in there because I think it had NHS numbers down the side. If there was the ability to then, click through and go into that person's sort of individual information, it just gives it that extra bit that drives that direct care benefit and helps us to use it to get the data in and get people engaged. Anyway, that was all I was going to say.
Thank you, Dean. That's really helpful. When we looked at the mental health dashboard last month, you saw that, it is going into that individual patient. So it is possible. That's what I'm saying. With the LD, they didn't want it at that level. The purpose of that was that. So, but we still have the patient list. If you said, oh, in order for this to work, you know, the feedback we want to give is like, you know, rather than just see the patient list, you want to click on the patient and get to like, you know, information about the patient, then that is the feedback that we want. Likewise, with the primary care system oversight, as it says on the tin, it was meant for a system oversight, you know, view. We can obviously the data has been built up from patient level data at the back. So if we were to like, you know, then take this down to the individual patients, yes, we can. So people can then focus on which, like, you know, this ethnicity, for example, I'm mentioning, rather than us give another, you know, point them to another dashboard, they can click on it and it can take them to a patient list as to like, you know, who haven't got ethnicity. So absolutely, we can do that. Again, you know, that's the feedback we want. In fact, we've been having that conversation internally in Northwest London to say, can
That's
we
great.
make this a single place?
I mean, we'll feed some of this stuff back. We're going to share some of these things. I know that performance is, you know, that anything performance is a challenge, and sometimes it you know, by us trying to push some of these things, it might have a detrimental effect to us getting people in sometimes. So we've got to kind of think some of that through, but we will feed some of this back and say, you know, identifiable and patient level and, you know, whatever, and then hopefully that can be part of the roadmap of building some of this out further. So that's great. Thank you.
Yeah. So the main purpose of these, like, you know, choosing this 6 dashboard was we will have the data for these 6 dashboards from LDS. That's one criteria. And the second criteria is, you know, there's a range of use case with this. Some are used for performance and quality monitoring. Some is used for direct care. Some is used for like risk identification. So we have a range of like, you know, use cases as well for all of this. So we thought we will give like a good mixture of things for us all to consider, including Northwest London, right? Because, you know, if there is good feedback from the others, Northwest London will also take it on board. It's not to say that, you know, we are going to stick to this and say this is the only thing we will do and we are not going to change it, etc. So Northwest London may also consider, oh yes, it'll be great. And to Carla's point earlier, if they think, oh, no, we want to stick to what we want to do, then they can have their own dashboard, but there will be a different London-wide dashboard. So that's, you know, the way forward. Right. Okay. Any more comments, suggestions? I'm conscious we have only 5 minutes, so I think it won't be fair to like, you know, talk about the Meds Data Gateway in 5 minutes because there's quite a bit to like, you know, show everybody on what actually, you know, gets shared with the national team in terms of like Meds data, etc. So you all are comfortable, confident about what goes, etc. So I suggest we push it into the next meeting. Along with the cervical and bowel screening and see how we do with the time. The 1 hour does fly, but then, you know, I don't want to rush it either where nobody has been able to ask question. Any other questions anybody has in the last few minutes? Rachel, so as an action, we should share the user guide for these 2 dashboards. And if you have
I'll
the
share-
videos as well, you know, we
Yeah,
should
I'll share
share.
the user guide. I'll send the link to the LAP
Yep.
videos, and I will also reshare the feedback form as well.
Yeah. So it's all in a single email from this, you know, show and tell. And, you know, just as a reminder again, hopefully we'll be able to talk about which 2 or 3 dashboards will be chosen to be scaled up at a London level in the January board, after which we will step up specific user groups. And I would really encourage the BI leads to be part of that as well, so that, you know, it's not, you know, BI doesn't get diverse from the conversation and it just happens with the operational clinical. So please do bear that in mind as well. And I'll continue to like let all of you know how this progresses. Because I've been asking for a really long time. There doesn't seem to be any consensus decision on which dashboards they want scaled up. Brilliant. Thank you all for your time. Have a good evening.
Thanks, Kavita.
Take care.
Thank you very
Bye.
much. Thanks very much.
Thank you. Bye.
Bye.